everybody out there. Hi, everybody out there in Zoom land. I'm Michael with Leading Edge, and I'm very happy to welcome you to this virtual lunch together with Martin Antony. These are kind of getting to know you sessions where we'll find out about Marty and his background and how he got into CBT work. And also for you, it's kind of everything I ever wanted to ask about CBT, but didn't have the chance. So whether or not you're someone who practices CBT or has been curious about it, we'll spend about half our time about accepting questions, and you can come on the screen or write them. I'll tell you about that in a minute. So there's kind of a double purpose. Get to know Marty Antony, get to know more about CBT. So let me just tell you about our format today. So first, on your screen, if you have your whole screen open, you'll see Emily Porter, who is officially our hostess with the mostest, which means she's there for you and for Marty. If you would like to ask a question for Marty, one way to do it is to put it in the chat line. The other way later on will be to use the wave function on the Zoom screen. Or if you have any technical problems or anything else at all, just put that in the chat line, and Emily will get back to you. With everything we do, we record these sessions and then we send them to you. So for those of you on the screen and the many other people who might not make it today but registered, everyone will get a link. If you want to watch something again, it will be yours. This is what we do. So we do these for our virtual free programs as well. In terms of what's coming up, this is kind of our little bit of a commercial for what we're doing. Since this summer, we have no paid programs, but we have a couple of more virtual lunches lined up for August. On August 16th, Bruce Ecker will join us. He is the developer and creator of coherence therapy. He's looked at his beliefs about how change happens, what happens in the brain, and looks for commonalities among many different therapies to look at the key ingredients. So he's a very interesting guy. He developed this, and he'll be with us for a free virtual lunch on August 16th. Later on in the month, we don't have the date yet, but it'll be later in August. We're going to have Mary Casamano, who is a social worker and therapist who's worked with Johns Hopkins for over 20 years, doing a lot of their research in psychedelic-assisted therapy. She's directed and led over 450 psilocybin sessions as part of the clinical trials. So this is an area that's getting a lot of publicity. We're curious about it. We'll have more on it ourselves, and she'll be with us later in August, and we'll let you know about that. Then on September 9th, our next virtual lunch will be with Sue Johnson, and we'll be sending out publicity. Sue, of course, developed EFT, emotionally focused therapy, and is always an interesting person to talk to. A couple of other things. We have a sale on our on-demand programs. We have a lot because we record everything and then we put them on demand eventually. This summer, we're having a 40% off sale. So if you're interested, check out our website, or Emily can put that in the link you'll get. Two other things. We have an EMDR program live in Vancouver. It's integrating EMDR into your practice. It's a 5-day intensive program at the end of this month in Vancouver, if that's all interest to you. And one more thing before I introduce Marty, we're letting people know, although it's still summertime, next February, we're having 4 weeks of workshops in Cancun at an all-inclusive resort, half-day programs with people like Bessel van der Kolk, Janina Fisher, Terry Reel, Diana Fosha. Lots of interesting presenters who've impacted the field of therapy will be with us in a beautiful setting. So whenever you start to think about, what am I doing this winter? Is it safe to travel? Is COVID okay in Mexico? And all those things. If the answer is maybe I'd like to go and hang out with interesting presenters and colleagues on a beach, we'll be doing that in Cancun. Emily will send you a link to that website. So that's kind of the commercial for the day. And now let me introduce Martin Antony. So Martin Antony is a professor in the Department of Psychology at Ryerson in Toronto. He also holds a part-time or adjunct faculty appointments at McMaster and the University of Toronto. He previously served as the department chair and graduate program director in the psychology department at Ryerson University. And he's also the founding director of both the Anxiety Treatment Research Clinic and the Psychology Residency Program at St. Joseph's in Hamilton. He's a fellow of the Royal Society of Canada and a past president of the Canadian Psychological Association. Marty's written 33 books on relating to anxiety, OCD, perfectionism, assessment. He's been presenting workshops for us for over 20 years. And I mean, always the question before I introduce Marty, how many books is it now? So it would be like 15, 20, now it's up to 33. So he is a real leader in this field. And he's also, and we'll ask Marty later about the provincial clinical and training, he's the provincial and clinical training lead on the Ontario Structured Psychotherapy Program. Also later in September, he will be leading a 3-hour webinar for us on shyness and social anxiety, effective treatments, and emerging approaches. So that's a little bit about Martin Antony. So Marty, I want to start off by asking you a question. What led you into this field of psychology? How did it all start? Go back to whenever it was for you. And first, welcome and thank you very much for taking this summer Monday to be with us all.
Thank you. It's a pleasure to be here and an honor to have so many people joining this call today. So thank you. If I go back to 1987, I guess. So at the time, I had switched. I had begun. I was at U of T in Mississauga from 83 to 85 and taking mostly kind of hard sciences, so biology and chemistry courses. My plan at the time was to go into medical school, and it wasn't working out. I was doing okay, but not well enough, I guess. I remember organic chemistry was a full year course. I managed to eke out a D. But I failed everything after the Christmas exam. I remember my MCAT getting the 37th percentile on the physics part. So there were a couple of things that were bringing me down, and medical school didn't work out. I found that I was doing okay in psychology courses, so I ended up switching halfway through my undergraduate degree to psychology. And in the end, applying to psychology programs. And I guess like a lot of us ended up doing something different than what I thought I was going to be doing. So after I finished my undergraduate degree, I applied for a job in schizophrenia, working with Ron Langevin and Mary Seaman, who some of you may know. And I applied for a job with Richard Swinson, who was a psychiatrist who was doing work in anxiety at Toronto General. And somebody else got the schizophrenia job, which is the one I really wanted. Anxiety didn't seem that interesting to me, and behavior therapy, there was a little paragraph on it in my abnormal psychology textbook at the time. It wasn't kind of a big thing. It didn't seem as interesting to me, but I ended up getting the anxiety job. So I ended up kind of falling into that by accident, really. And then once I was there, I found that I really loved what I was doing. It was an area that was growing. It was an area where people actually got better. We had effective treatments that were in development in the mid to late 80s. So I applied to graduate schools to work with people who were doing work in that area. And the more I did it, the more I loved it. So here I am now, all these years later.
And I wonder if I remember back then, my background was social work. The camps in the therapy worlds were much stricter than they are now. I think there's a lot more integration. So there were like the Gestaltists, and there were the family therapists and the behaviorists, and they didn't seem to meet very much at any point. And there's almost seemed to be hostility between the various approaches to therapy. Was that part of what you saw at that time when you began your interest in working in the field?
So they were certainly taught as very separate kinds of schools. I think they're still probably described that way in undergraduate psychology classes anyway, as these sort of separate schools. The reality, as you said, there is a lot of overlap. And I think there was then. When I look at Gestalt therapy, there's a whole lot of things in there that are very behavioral, where people are asked to do role plays, for example, or they may practice a conversation with a loved one that they find difficult doing, which can look like exposure therapy. Remember a talk, Les Greenberg was giving a talk at McMaster when I was there years ago, and he was talking about EFT, and a lot of the strategies, I don't have any formal training in EFT, but at least from his talk, a lot of the strategies looked very similar to what I might do with people in behavior therapy. And then, another example is John Carlson. I was recording a video for the APA video series, and John Carlson, who's an Adlerian, or was an Adlerian psychologist, he passed away a few years ago. He was hosting this series, but just before I recorded mine, he was recording one for the series, and I was watching him do Adlerian psychotherapy, and it looked, very much to me like cognitive therapy in a lot of ways, challenging beliefs. And I remember saying that to him, and he reminded me, I had forgotten this, that both Beck, who developed cognitive therapy, and Albert Ellis, who developed cognitive therapy before Beck did, just didn't call it that. He developed rational emotive therapy at the time. Both of them credit Adler as influences. So I think even back then, even if people didn't talk about integration as much, there wasn't an integration movement as much back then. Actually, I shouldn't say that. There were people trying to integrate psychodynamic and behavioral treatments back then. But anyway, it's a much bigger thing now. I think the overlap was there then as well. And of course, the active, we know that the non-specific factors, having a good therapeutic relationship, for example, and strong communication and responding to resistance in particular ways, those are things that seem to be important ingredients across all psychotherapies as well.
Yeah. And it seems in the CBT field that there's been more acceptance of acceptance-based therapies and mindfulness. I remember hearing a story from Paul Gilbert, he's an English psychologist who developed compassion-focused therapy, applying to present at some major American behavioral conference maybe about 20 years ago, and he was told it wasn't acceptable. He couldn't be presenting there. And now I understand that a lot of behavioral conferences, CBT and others, are just full of programs related to the research and practice of mindfulness. So can you tell us a little bit about that?
Yeah, I would say that one thing that unites many people who started off from a behavioral perspective is the focus on evidence. So people were doing behavioral treatments because there was good evidence that they worked. There were randomized controlled trials and a whole range of other kinds of studies, a lot of case studies initially, sort of single case experimental kinds of studies, basically showing that behavioral treatments worked. And that was sort of the value that a lot of behaviorists had, is this sort of emphasis on evidence. And what happened is, over time, evidence has started to support other kinds of approaches as well. So cognitive therapy before long had a lot of research supporting it, and behaviorists started to expand. Not everybody, of course, a lot of people don't like to change and don't like to incorporate new things. So there are a lot of people who didn't. But for a lot of us, cognitive therapy became sort of a way of expanding behavioral treatments to broaden them. More recently, acceptance-based approaches, which I see as very compatible with behavioral approaches, have been popularized by people who were very behavioral. So Stephen Hayes, who developed acceptance and commitment therapy, was very much a Skinnerian behaviorist when he started. And again, the evidence has been really supportive. Probably when I started working for you, I would have described mindfulness as an alternative or kind of treatment, because at the time there just wasn't a lot of, it had been around for a long time, but there wasn't, there were not randomized controlled trials in anxiety, for example, with mindfulness. So over time, I think behavioral treatments have expanded to include those. I think behavioral treatments have also expanded to include things that are clearly not traditional behavior, other things that are not traditional behavioral treatments. A good example is motivational interviewing. There's nothing traditionally behavioral about motivational interviewing, But we know that it makes behavior therapy more effective if we respond to people using strategies that Carl Rogers developed in the context of client-centered therapy, if we respond to resistance using those kinds of strategies. So the boundaries, we have this debate. I'm the past president of the ABCT, the Association for Behavioral Cognitive Therapies. And one of the things we debate about all the time is, are we an association? Are we a CBT association, or are we an evidence-based therapies association? We never get anywhere with that debate because I think there are arguments always for sort of staying focused on CBT versus broadening, because the reality is many of our members are doing lots of different things other than sort of pure CBT. So that's my long rambling answer to your question.
That's a great answer. You mentioned the importance of the evidence-based aspect of CBT, and I think it really was embraced by a lot of organizations and governments, funding organizations, because maybe 30 years ago, people could get funding, organizations could get funding by telling some anecdotes of how they helped somebody. But CBT came in with powerful evidence that it worked. And I wondered, when you look back at those days, what was some of the early research studies for anxiety or anything else you choose to mention that really showed therapists and also funders that this was something that was working?
Yeah, so around the time that I was getting started in the area, there wasn't a lot of research yet on cognitive therapy for anxiety. There was research on cognitive therapy for depression at the time. So there were some very early studies on looking at cognitive therapy for depression compared to medication. I think it was imipramine, tricyclic antidepressants, showing that they were equally effective in the 80s. There was also an early study in the 80s comparing CBT to interpersonal psychotherapy for depression that found them both to be very effective treatments. So those are some of the early cognitive therapy studies. In terms of behavioral treatment, Jack Rackman, originally in London and then eventually at UBC here in Canada, did some early studies with Isaac Marks on exposure-based treatment for OCD that found it to be very effective. They used relaxation training as a placebo kind of treatment and found that exposure was much more effective than relaxation. There were early studies in panic disorder being done by David Barlow, who is my mentor at State University of New York at Albany, where I did my PhD, and also David Clark in the UK, who was doing more cognitive work. They were doing, anyway, all of them were doing work in panic disorder. One of the early studies in panic disorder was one that was done here in Toronto. Richard Swinson collaborated with Isaac Marks in London to look at, again, purely behavioral. There was no cognitive strategies, but an exposure-based treatment compared to relaxation. They also had a medication arm for panic disorder. And I was lucky enough to be a research assistant on that study in between my bachelor's degree and my graduate degree. And I remember when they tried to publish it, the psychiatry journals wanted nothing to do with it. So they believed that they were sort of faking the data. There's no way that these psychological treatments could work as well as medication treatments. That was the concern at the time. And so they actually, this was even before they submitted, even at conferences, some of the more biologically oriented psychiatrists in the area of anxiety were outraged that this was even being presented at the American Psychiatric Association meeting, these data showing that not only did they find that in the short term that behavioral treatments, exposure for agoraphobia was as effective as medication. They used alprazolam or Xanax in the study, but they found that after 43 weeks of follow-up without any treatment, they saw much higher relapse rates in the group that had medication than they did in the group that had psychotherapy. So this is one of the first studies to show that really the long-term effects of cognitive, in this case it was behavioral treatments, are much stronger than medications once people stop all their treatment. And again, the psychiatric community at the time was outraged by this. So these were still, there was a long history of behavioral kind of research in psychology, I think, but it was only really in the 80s that it started to spread to beyond, behavioral psychologists in their little labs doing what they're doing. And yeah, initially it was not accepted, not surprisingly. So yeah, things are very different now.
So bring us up to date. If someone, and we have mostly therapists joining us today, what would you say in terms of populations that CBT is most useful for? And the second part would be, what are the populations that might be less useful for?
So there's evidence supporting CBT across a wide range of problems. So we know for anxiety-related problems, CBT is effective, and there's not a lot of other forms of psychotherapy that have sort of a strong research base in anxiety disorders that compares to CBT. So, for example, if we think about OCD, really cognitive behavioral treatments are the only treatments that I would say are evidence-based in OCD. We have a lot more competition, though, in depression. So in depression, there's at least 7 or 8 psychotherapies that are evidence-based, and there's no strong evidence that any of them are any better than any others. So things like emotion-focused therapy and couple therapy and interpersonal psychotherapy and short-term psychodynamic psychotherapy and cognitive treatments and behavioral treatments. I know I'm forgetting 1 or 2 others, but they all seem to work about equally well. So it does vary a little bit from problem to problem in terms of what the range of evidence-based kinds of therapies are. So that's not to say that some of those might not work in OCD. It's just that they haven't been tested in the same way that cognitive behavioral treatments have. But there's evidence supporting CBT for eating disorders, and when I'm using CBT, I'm using it as an umbrella term. So that encompasses all behavioral treatments and cognitive treatments. And so I'm not talking specifically about cognitive therapy when I say CBT. So I consider relaxation training as part of CBT. We know that that's effective in generalized anxiety disorder, for example. So depending on the problem, different strategies are more or less useful. So in specific phobias, things like snake phobias, a few hours of exposure therapy is really the most effective kind of treatment. There's not much evidence supporting cognitive therapy for snake phobias. There's none. So depending on the problem, different strategies are going to be more or less useful. There's evidence supporting cognitive and behavioral strategies for schizophrenia, for bipolar disorder, not as standalone treatments. So the assumption there is that people need to be on medication in most cases, but there is evidence that CBT will prevent relapse in those problems or basically enhance the effects of medication, especially over the long term. So whereas that's not the case in OCD, there isn't the assumption that people need to be on medication. Medication alone is as effective as behavioral treatments alone. So the role of CBT really varies, I guess, depending on the problem. I can't think of a problem where CBT is not effective, but another psychotherapy is. So I think pretty much in every problem where psychotherapy has been found to be useful, CBT is one of those therapies that's been found to be useful. However, a lot of people don't respond to CBT or any other psychotherapy or any other treatment that we're giving. There's no problem. There's no treatment that works for 100% of people with a given problem. So another way I can answer your question is not so much what problems does CBT work for, but are there people within a group for whom CBT may not be effective? And the answer is yes, and a little bit of it is guessing. I mean, we do have some data to show that for some problems, there are reliable predictors. So in OCD, people who have had OCD for a much longer time don't respond as well to CBT, but they also don't respond as well to medication. They probably don't respond as well to other psychotherapies, would be my guess, although that hasn't been looked at. Comorbidity sometimes can lead to worse outcomes if somebody has a lot of complexity, maybe personality disorders and significant substance use. Their CBT for panic disorder may not go as well as somebody who has less complexity. We know that people's expectations for therapy have a big impact on outcome. If people believe that the therapy is going to work for them, then on average they do better. So some people their beliefs about what's causing their problem or maintaining it may be better aligned with a non-CBT kind of therapy, and they may get more engaged in that kind of therapy. It may be a better fit for them. So in those cases, CBT may not be a great fit. The other thing I'll talk about is diversity. So historically, a lot of these treatments were tested primarily in the US and Canada and the UK, primarily with Western kinds of cultures, less so now, but certainly when these were being developed, mostly with white clients. The question has come up is whether CBT is an effective treatment for people who don't come from that background. So people from different racial backgrounds, different cultural backgrounds, Indigenous clients. The reality is there are more studies in non-Western groups. If we look at psychotherapies that have been tested in non-Western groups, so we look at studies on psychotherapy in Indigenous clients or psychotherapy in non-Western countries, in India or in African countries and so on, the treatment that's most evidence-based in those groups is still CBT. I mean, that's still the one that's been studied the most. It's been studied way less in those groups than it has been in Western cultures, again, in the US and UK and so on. But it still has been studied more than other psychotherapies to date, and generally has been found to be useful, but often it's adapted. The metaphors that I might use with a white client might not have the same impact with an Indigenous client, for example. For one thing that I've talked to people who work a lot with Indigenous clients, and their recommendation is training up Indigenous therapists in CBT who can bring the culture into the therapy in a way that's effective, use metaphors that are effective. But their experience, and again, there's not a lot of research, but their experience is that that these, some of the basic principles of CBT are not culture specific. If we look at exposure therapy, it's just the idea that the more you do something, the easier it gets. That doesn't seem to be culture specific. It's not even species specific. There's tons of studies, and my dog got over a fear of going for walks by just going for walks. What is culture specific is how we package the treatment, and how we describe it, how within a cultural context. And for that, there's still a lot of work that needs to be done in terms of adapting treatments. But the little bit of work that is out there on adapting treatments seems to find that it's useful.
I'm really glad you raised that issue. My next question, you answered it. By the way, everyone watching, if you have questions you'd like to ask, we're going to open up in just a few minutes. Put them in the chat line, or be prepared to raise your hand either on the screen or in the old-fashioned way. So, Martin, you've done so much work in anxiety, different types of anxiety, and you're going to be presenting for us on social anxiety. I wonder what you think the next few months are going to look like in terms of people with social anxiety. They've been joined by a lot of the rest of the world who are not diagnosed. And maybe there was some comfort in thinking that everyone is joining them. But now people are coming out, going out, doing things that weren't expected, several months ago. What do you think the effect that will be on people who have social anxiety?
Yeah, so this is it's mostly speculation, but I can share with you what I think will happen. A lot of people who were more introverted actually did pretty well during the pandemic. I remember some journalists talking about how they've been, this a couple of times over the last year and a bit, is how they've been training, they're introverts and they've been training for this pandemic their whole lives. And now, they're ready to not socialize with other people. So I think for people who are more introverted and more socially anxious, and you can be introverted and not be socially anxious, but often they go together. At the best of times, it's hard, to get out there and make small talk and network and, all those things that we often have to do in the context of our work. After not doing it for a long time, it's even harder. We know that that's the case for almost everything that you kind of don't want to do. If you haven't done it for a while, it's harder. One question I often ask audiences is, what's the hardest day to drag yourself into work? And for many people, if you work Monday to Friday, the answer is Monday. And it's even harder after a vacation. Now, you might think it shouldn't be because you've had a rest. So you're rested and ready to get back into work. But for a lot of people, it's harder after a rest. So after a year and a half, if it's something that you find difficult, it's going to be potentially that much more difficult. And for most people, they're just going to do it anyway because they have no choice and it'll get easier. But for some people, I suspect it's going to be very difficult to the point that they just can't do it. They may leave their jobs, or they may just really struggle at work for a while. We have seen this with other pandemics, that a lot of the problems that begin during a pandemic, things like anxiety and depression and post-traumatic stress, often they go away. They get better after the pandemic, but for some people they don't. So the problems continue after the pandemic has ended.
Well, it will be interesting to see. I'll ask one more question, then we're going to open it up. I've asked you about the history of CBT and where it comes from. And, one thing that's always been of interest to all of us at Leading Edge is how therapy changes and what the leading edge, what's next. If you were just guessing about the future, and there's no evidence or no research, I don't think, if you were guessing on the future, 5, 10, 20 years, what do you think the therapy world will look like in terms of what's been learned from CBT or anything else?
Well, one thing I think will happen is that CBT is it's very popular right now, but I suspect in 50 years something else will have replaced it. I don't know what that is, but if I just look at the history of therapy, therapies kind of evolve, they come and go, they get renamed, repackaged in different ways. So I suspect we won't be talking about CBT that much in 50 years. That would be just a guess. Again, I have no reason to think that. If anything, it's just been growing, but I don't see that happening if we look at things historically anyway, that continuing. So that's one thing. I remember Joseph Wolpe I was presenting a poster when I was a graduate student. Joseph Wolpe developed systematic desensitization and was a behaviorist, right until he died. And I remember when he was at my poster, he was complaining about all these cognitive people who were trying to change behavior therapy and how horrible that is, basically, it's now we look back and it's just the way it is, right? Cognitive therapy has become sort of a big part of what we do. So I suspect the same thing will happen at some point with whatever I'm doing now. So that's one thought. If we look at things, not so much 50 or 100 years ahead, but in the more immediate kind of future, some of the things that are happening that I think are interesting, I don't know whether they will evolve into anything, is trying to, one thing is precision healthcare, trying to match treatments to individuals to get them the treatment that's most likely to be effective for them. And there's been some people, Rob DeRubis in Philadelphia, for example, has done some work on this in the CBT context. There are people who are trying to use a neuroscience kind of perspective to see if we can predict who will respond to what treatments. So that's something that may continue to evolve. There have been attempts at this in the past that haven't really gotten anywhere, but I think people are looking at that in new ways. Another thing is trying to get treatment to more people. So this is something we're doing in Ontario. We are well aware that the demand, if we think about 20% of people having some sort of anxiety problem or depression. There is no way to meet the demand with 100 positions that are $100,000 a year. So psychologists, social workers, nurses, people who are doing this work, there's just no way that we can meet that demand. So is there a way that we can deliver treatment more broadly using a stepped care approach, where we know that there's now good evidence that some people, a big percentage of people, can do okay in a more self-directed kind of approach, where it could be self-help books, it could be internet-based CBT that are supported by a therapist. So it's not like you're on your own, but it's not 15 to 20 weekly sessions that each last an hour. It might be 6 sessions that are a half hour, combined with a self-directed component. So they've done this in the UK very well with a program called IAPT. It's Increasing Access to Psychological Therapies, where people begin with, most people begin with a lower intensity treatment, a self-directed treatment with some therapist support, and about half of them step up to a full course of CBT. But about half of them don't. So many of them do well with a low intensity treatment. What they've been able to do is reduce wait lists so that the time from referral to the first session of treatment is 6 weeks. I think 80% of people get their first treatment session within 6 weeks, which is really, we've got lots of people who are waiting for 6 months or a year to get specialized kind of treatment. So, and there's still that opportunity to step up to higher intensity treatment for those who need it. Another thing they've done is 98% of their clients provide weekly data. So, and the data are used not just to evaluate the program, although that's part of it, but they're used as part of the therapy. So the client can monitor their progress over time. The therapist can monitor progress over time. The client can see graphs of their progress over time. If they've had a bad week, they can talk about why that is. So it's very much a measurement-based care kind of process. And a lot of us worry that if we make clients fill out measures, they're going to complain or they're not going to like it. They've got good data suggesting that it actually engages people more when you use the data. When you use the data, if you just have people, well, I'm getting an echo now. Okay, it's better now. If you have people just fill out questionnaires and you never talk about those questionnaires, that's not going to be helpful. But if it's part of what you're doing with people in the session, it engages therapists more, it engages clients more. So that's an important piece of what they're doing there as well. And because of that, they've got a system that learns. So if they've discovered that some services in the UK are not doing as well with their outcomes, they can then dig in to find out why. And they've been able to bring up, improve outcomes in certain areas of the country by having this really rich information about how clients are doing. So why am I talking about all of this? Well, in a number of countries, they've started to model programs after this program in the UK that's been going on for 2 years now, or 10 years now, over 10 years. So in Israel, in Norway, for example, there are similar programs, and now in Canada. So in Ontario, the previous Liberal government launched a pilot to test out whether this would work in Ontario. And the current Conservative government basically approved transitioning this pilot program into a permanent program. So we still have a lot of work to do. There's lots of therapists to get trained up, lots of therapists to hire across the province. There probably isn't enough money devoted to the program right now to do it well, but hopefully that will grow if we can show that it's useful. The stepped care framework, we have some low intensity treatments and high intensity treatments, but the stepped care framework isn't working quite as efficiently as we'd like it. Our wait lists are still too high. So we're kind of in a transition phase, but we're working toward having a program similar to the one in the UK. There'll still be, of course, everything else that's available out there now as well. So it's not replacing what's out there, but rather adding a new option to what's out there now. And the plan is to make it available across we now have networks identified right across the province. So that's called right now it's called the Ontario Structured Psychotherapy Program. I'm the clinical and training lead for it. And there's a whole bunch of different groups working for it. And I mentioned the Liberal and Conservative government specifically, because one of the things that I've heard from David Clark in the UK is that all governments love the program in the UK because people get better and it saves money. No, I mean, there are criticisms of the program and saying everybody loves it, but governments tend to love it because it meets those two important needs, which has been really helpful for just knowing that it's going to keep going forward there.
Thank you very much for raising these, I think, promising ideas and projects going on. We're going to open for questions. Emily will take over. And if you come to the screen, let us know where you're from. It's always kind of fun to know that. Emily, what do we got?
Yeah, we have a couple questions. Our first one is from John. John, did you want to unmute?
Yes. Yeah, thanks. I'm from Mississauga, just outside Toronto. I do family and emergent medicine. And a question for Dr. Antony. There's a patient who's done quite well with CBT with her, I wouldn't say lifelong, but certainly since her late 20s, early 30s, GAD, and has done very well with CBT. She continues, though, to have episodes where, not associated with worries or thoughts, she gets a non-specific sense of anxiety. I wouldn't call it quite a panic attack or doom, but more a little bit of dread, some minor somatic symptoms, a little bit of shortness of breath, a little bit of an awareness of her heart, but not really racing, sweating with it. And it doesn't seem to be associated with a particular worry. Certainly she knows about those, having dealt with it and applied CBT strategies to it. And she's a little bit of a loss. I would say she's dealt with it pretty well by, not magnifying it. At one time she tried to find a reason for it, and that might lead to some ruminative. And now she sort of just accepts it, breathes through it, and waits for it to take its course. But other than that, is there any other approach to it, any other consideration?
So it's hard to know for any one individual, but in general, a couple of things I would think about. One is that it sounds like a kind of typical CBT outcome for GAD. So, most people I've treated with any kind of anxiety problem still get anxious from time to time, and they're coping with it better, and it's not affecting their relationships as much and doesn't affect their work as much, but it still happens. Most people without anxiety disorders struggle with anxiety from time to time and get that knot in their stomach, and they may not always know why. One possible way of thinking about it is that she's now kind of like the rest of us. It's possible that maybe she is more anxious than the average person, and it's sort of what's left of her GAD. And we don't have a lot of great data on what to do with that, but there are certainly other treatments that are effective, and maybe she could take it a little bit farther with some other approach. So the ones that come to mind for me, mindfulness and acceptance-based treatments, progressive muscle relaxation, breathing strategies, aerobic exercise. There's some data supporting yoga, other psychotherapies. There's a bit of research in GAD on just other kinds of psychotherapy as well, and maybe there would be something that would be a good fit for her interests. So it's possible she could take it. There are some people who have integrated. Michelle Newman at Penn State University has integrated interpersonal components into the CBT and has gotten good outcomes with that. So if there are interpersonal, it sounds like she's not really aware of any particular worries, but if there are interpersonal stresses for her, focusing on some of that may be useful. So again, it's hard to know for that individual, but those are all some possible directions that somebody could take. I think a big part of it, though, is also acceptance. it's much easier to deal with anxiety when you kind of normalize it and you realize that you don't have to fight it. It's how you're feeling at this moment, and whether you fight it or not, it's going to go away. It's not going to stay exactly the way it is right now, and just that can take the edge off sometimes.
Thank you.
You're welcome.
Yeah. Our next question has been asked if it can be read. Would you? Sorry, too many questions coming in. Actually, I see Louis' hand has been up for a while, so let's get Louis' question asked.
Yes, in fact, I have two brief questions. I think they are brief. The first is, I believe in CBT. I've followed Kristen Padesky's each year when she was coming to Toronto and got a lot of good benefit of her advice or courses. Now, considering the case that are not responding well to CBT, I've come in my practice to have a lot of complex PTSD, and I mean with this, people who have been abused, often by their family from childhood up to adulthood. And I find that CBT doesn't help them a lot, and I have started a few years ago to use IFS and found better result. Can you comment on this? And there's another question afterwards, brief.
Yeah, so I don't do work in trauma. I don't follow that literature as closely, but I've had some discussions. I guess what I would say is there's some debate out there about the construct of complex PTSD and whether it needs something different. So my colleague Candace Munson, who's at Ryerson, she's one of the developers of cognitive processing therapy. I know that she would argue that that there isn't a strong evidence base for special treatments being needed for complex PTSD. I know other people would, but I don't know the literature well enough to be able to have an opinion. But a couple of things that I can say, there have been a couple of recent reviews looking at comorbid PTSD with borderline personality disorder that have found that combining DBT strategies with more traditional cognitive behavioral strategies for trauma can be a useful approach for that population. And there are also studies in comorbid substance use and PTSD suggesting that combining strategies for the two of those can be useful. So combining processing therapy or prolonged exposure, for example, with motivational interviewing, some of the other strategies that are used in substance use problems can lead to positive outcomes. So I'm aware of some of those studies, but that's, it's not my area. I haven't treated trauma or done research in trauma, so that's my limited answer anyway.
The second question is regarding government and also your comment about psychotherapy being needed and as efficient as medication, often more efficient. And recently, and you are in Ontario, so you are probably aware of some psychiatrists placed in the province suggesting that we should stop doing psychotherapy and focus on medications. What's your comment on that? Because that's given lots of difficulty, the government seeming to support that view.
I guess I will answer that question specifically for my area, which is anxiety disorders. There is evidence that from a cost perspective, in the short term, medication is cheaper. So if you just look at the 12 weeks that people are in therapy or whatever, medications are less expensive. Yeah. Over the long term, medications are more expensive if people stay on them. And if they don't stay on them, then we see higher relapse rates. So my view is that it's a short-sighted approach to at least dealing with anxiety disorders and OCD, which are my area. So there may be other areas where there's also the other thing I would add is there's good data that medications are used much more widely than psychotherapy, but there are also good data showing when you give people the choice, the majority of people prefer psychotherapy. Another reason not to use medications is that people don't want medications. but more people prefer psychological treatments over medications. So, I wouldn't. I would argue against that recommendation myself.
Thank you.
Thank you. Our next question is from Deborah and then Jose.
Okay.
Deborah, did you want to unmute?
I can. Is it what's new with the process of exposure therapy?
Yes.
Okay. I can take a stab at that. So I'd say there's two big things that are new. So one thing is work being done in an area called inhibitory learning. So Michelle Krask has UCLA sort of got this area moving. There've been lots of other people doing work in the area as well. So it's basically taking a cognitive approach to understanding the effects of exposure. At least that's how I think about it. What Michelle Krask has argued is that what's most important during exposure is what people learn during exposure. So the goal of an exposure session shouldn't be necessarily to stay in the situation until the fear comes down, but rather to stay in the situation until the person has learned what they need to learn. So they've learned that the situation isn't dangerous, for example. And there are a whole bunch of other predictions that she makes. So one of the hypotheses in inhibitory learning theory, I should just mention it's called inhibitory learning because the idea is that exposure does not replace the original learning. So if somebody learned to fear cars because they were driving because they were in a car accident, exposure doesn't undo that original learning, but it inhibits it. So it adds new learning that inhibits the impact of that original learning. So that's why it's called inhibitory learning. So she also says that people get the most out of exposure when they're surprised and when what they're expecting is very different from what happens during exposure. So she recommends a whole bunch of different strategies to increase that discrepancy between what they're expecting and what actually happens. So one of the predictions says that people should not do cognitive therapy immediately before an exposure practice. Because if you challenge all of your negative thinking before you do the exposure, you're going to go into the exposure expecting things to go okay because you've done all this cognitive work, and then things are going to go okay, and there's not going to be that discrepancy. You're not going to learn as much. Whereas if you go in kind of expecting things to be terrible and then they're really good, you're going to learn something from that. So she recommends using cognitive strategies after the exposure practice to kind of reflect on what's happened during the exposure. So almost treating exposures as behavioral experiments where you make a prediction, you do the exposure, and then you reflect on what happened. There are a whole bunch of other recommendations as well. Some of them have been supported by evidence, some of them haven't. We just submitted a paper for publication showing that whether you do cognitive restructuring before an exposure practice or not, this is in a study of claustrophobia, didn't seem to make a difference in our study. Everybody got better regardless. So that's just one study. I'd say the evidence is mixed. Some of her hypotheses have been supported, some haven't been, but it's kind of a really popular thing in exposure therapy that people are talking about. The other thing that I'll mention is, and by the way, I'll be talking about it a little bit in my social anxiety seminar in September as well. The other thing that I also will be talking about a little bit is research on D-cycloserine. So this is an antibiotic, at least it was developed as an antibiotic originally, but it also has effects on the brain, and it seems to enhance learning. So there's evidence that if you take D-cycloserine just before you do an exposure practice, you get better outcomes in exposure therapy, at least early on. If you keep doing this week after week after week, eventually people who had placebo with their exposure, they kind of catch up. But at least in the early sessions, the D-cycloserine seems to enhance the learning that happens during exposure practices. So that's led to a whole lot of research as well. I would say it hasn't led to any change in terms of how people practice clinically. Like I don't know anyone out there who's doing exposure combined with D-cycloserine outside of the context of research, but there's been lots of research on D-cycloserine and other substances that seem to enhance learning, combined with some learning experience. So those are a couple of areas that have grown. I'll stop. I realize we don't have a lot of time left and we have lots of other questions, but.
Jose, let's get you unmuted. Hi.
Yes, hello. Hello, my name is Jose. I am from Colombia, but I live in Mississauga, Ontario. I just have a quick question about the OSP program. I just would like to know if it includes also third generation approaches or just cognitive, or if it includes also third generation or also behavioral, is pure behavioral. And also I'm curious to know about the training, like is that something that one can access directly or it has to be accessed through specific places where people work, or how one could access the training?
Yeah, that's great question. So we are in the early stages with OSP. So I would, right now it's primarily traditional kind of behavioral and cognitive behavioral approaches. So we're using Edna Foa's treatment for OCD and David Barlow's treatment for panic disorder. We're using cognitive processing therapy and prolonged exposure for PTSD. We all recognize the benefits of acceptance and mindfulness-based strategies. And I suspect that once we get the infrastructure running, we'll be in a position to start adding other kinds of therapies, including mindfulness and acceptance-based therapies, for example. A high priority for us is to get motivational interviewing integrated into the program. It's not there yet. So the plan is to expand beyond CBT. So sort of the quick answer. In terms of the training, we have a very comprehensive training program that includes online training that includes, some of it is self-directed, but there are also students get together with a facilitator and work through different problems and do some role plays and things like that in addition. So it's this hybrid kind of model. And then everybody gets a weekly clinical consultation that goes on for at least a year as well, in addition to these training courses. So the whole training process takes 12 to 18 months. Right now, it's only available to people who are employees of one of the OSP services. That doesn't mean that that won't change. In fact, we've talked quite a bit about opening it up, maybe in a modular kind of way to people outside of OSP, but there's no immediate plans to do that. So I think I answered, was that all of your questions or was there a third one?
No, that's all. Thank you.
I see there is a question about the OSP website. It is not, we don't have a website yet, but apparently it's coming. So the new Mental Health and Addiction Center of Excellence and their communication people are putting something together. What we do have right now, I have written articles for the CACBT, the Canadian Association for Cognitive Behavioral Therapies newsletter. I wrote an article for the ABCT, the American CBT Association newsletter, and I also wrote an article for the Canadian Psychological Association's newsletter called Synopsis, with a P in front, PSY, Synopsis. So there are descriptions of it in some of these publications. I'm happy if anyone emails me at my Ryerson address. It's Antony, MANTONY. There's no H in Antony, at ryerson.ca. I'm happy to send you links to a couple of those articles, but that's all there is. Oh, there it is. Thank you. But that's all there is right now. There is no website, but it's coming apparently.
Well, actually, that leads into my closing, which is first to say, Marty, well, if you want to send the articles to Emily, she can put them in the message that goes to everybody tomorrow with this video. Also with the spelling of the antibiotic, which Louis has asked about, that you mentioned. So if you want to send those, we can send them out to everybody, if that's okay.
Sounds good. The antibiotic I just put in the
Oh, okay.
chat, but I'll make a note to send the...
And we'll send that out anyway, because the people who aren't here today who might view this, everyone will get it. So
Okay.
We'll do that. Well, listen, this was a fast hour because you provide so much information, and all those research studies in your brain are very, very impressive, I'm sure, to everyone. So thank you so much for joining us, and thank everyone for watching. And joining us, asking questions. It always makes this a very alive process. And I know we have people from all around the world joining us today, and that is very exciting. So we always close, Marty, this way. We open all the microphones. We let everyone say thanks and whatever else they want to say, and we'll close for today. You'll get that message. Hopefully you can join us. And Marty, you might be interested in Bruce Ecker's work on August 13th. another interesting virtual lunch speaker. So thank you all for joining us. It's great having you as part of our community.